Hello, everyone. Thank you for inviting me to be a part of the network of the National Library of Medicine's COVID-19 Infodemic Virtual Symposium. I'm Dr. Cameron Webb, and I serve as a Senior Policy Advisor for Equity on the White House COVID response team. I'm happy to be here today to discuss the priorities that are guiding the administration's work. Now, this past year has been more challenging than any of us could have predicted, but has also brought some fundamental structural problems into the public consciousness. There are conversations happening right now that are long overdue. Conversations meant to address the historical patterns of inequity that permeate our entire society. These inequities exist throughout our social world. They're present in our daily interactions and in the structures and systems that shape our lives. But as we build our COVID recovery strategy, we are addressing these crises in their complexity. Not only do we need to defeat the virus, we also need to heal from these chronic disparities. This is why equity is front and center as we press forward. In the near term, we're prioritizing equitable distribution of COVID-19 resources, such as personal protective equipment like masks that are still essential, testing, therapies, and yes, of course, vaccinations. I'd like to speak about our goal to efficiently and equitably vaccinate the entire country. The federal government is committed to a data-driven strategy to target vaccines to the communities that face the most substantial access barriers. This strategy includes a commitment to supporting vaccination centers as necessary to get the pandemic under control. The Biden-Harris administration launched 4 direct federal vaccination programs in the first 3 weeks: community health center partnerships, retail pharmacy program, community vaccination centers, and mobile vaccination sites. These programs were expanded over the past few weeks and are being executed to make sure that we reach the hardest hit and highest risk communities. We're using metrics such as the CDC's Social Vulnerability Index to help target these resources. Plus, we're emphasizing the need to work closely with community and faith-based organizations to be most effective in connecting with their clients and members. And we're working directly with state and local leadership on each of these programs as well. As we talk about vaccine distribution and access, we are also aware of the role that trust plays in achieving comprehensive vaccination across the country. Trust in the vaccines is increasing among all racial and ethnic groups, and that's really encouraging. But we know that there's still a pervasive and unjust difference in how communities of color experience the medical system. Now, communities of color don't have to think back to Tuskegee or Henrietta Lacks to name the injustice in the healthcare system. They only need to reflect on their own experiences and those of their family members to recall instances of receiving subpar care. We have to partner with trusted messengers in communities and make spaces to hear and respond to the rightful concerns of those who've not always been treated with dignity by scientific institutions. There's a long and dark history of mistreatment of communities of color by the government and by the scientific community. So to earn back this trust, the federal government must involve communication and collaboration with community leaders at every step along the way. State, tribal, and municipal governments, church leaders, nonprofits, and more. We are providing culturally sensitive public health messaging to ensure that all communities have access to the important information about the safety and efficacy of these vaccines. The work that you are doing to address misinformation and mistrust and to develop strategies to make accurate health information available to marginalized communities is absolutely vital. Ensuring that health professionals and communities have access to and the ability to understand health-related data is the path to enabling all communities to make informed decisions about their health. In addition to equity and access to testing, treatment, and vaccination, we must ensure access to the scientific discoveries that propel these advances. Populations under study are rarely included in a meaningful way in the development of research. As we center health equity and health disparities in our COVID research, we need to collaborate with providers and medically underserved communities every step of the way. These communities know about their needs in a way that medical researchers do not. And because of this, it's both practical and right to involve them in developing research measures, prioritizing research topics, defining ideal outcomes, and implementing projects. However, there are institutional barriers to this deep and meaningful inclusion of communities in research. For starters, communities of color often lack the trust or interest to become involved in this research. And this is due to decades of systemic neglect, discrimination, and mistreatment experienced by communities of color at the hands of government and scientific institutions. And many communities of color, undocumented immigrants, indigenous populations, have been excluded from national health programs. That trust must be rebuilt and must be demonstrated through word and action. Medical professionals have an enormous role to play in connecting with their patients and communities and in sharing accurate information as trusted messengers. The other important part of rebuilding trust is making sure that people can connect with vaccination easily when it's their turn and when they are at yes. Community-based organizations, faith and community leaders, and others are also key in this work. Recognizing and supporting the important role of these critical partners will also go a long way in bridging the distance between many communities and medical institutions. At the federal level, the administration has committed to building trust within these communities. The president and other leaders will be honest and transparent with communities, maintaining an open line of communication and providing the public with clear, scientifically backed information and recommendations. As we center on vaccines as our most promising way out of this pandemic, we are also prioritizing investment in long-term public health infrastructure. Marginalized communities all too often lack access to meaningful, affordable, and high-quality healthcare. That's why the federal government will strengthen health capacity, creating a public health workforce program of community-based workers to serve the communities in greatest need. These workers will be recruited from the communities they serve in order to sustain trusting relationships with local residents. The federal government is partnering closely with community health centers and federally qualified health centers. The nation's 1,400 community health centers provide primary care to nearly 30 million people, the majority of whom are people of color. That includes 1 in 5 rural residents, 1 in 3 individuals living in poverty, more than 1 million agricultural workers, and more than 1 million people experiencing homelessness. A crucial part of building our public health infrastructure is securing needed data on race, ethnicity, and other key demographics of populations. We need to collect place-based data that allows us to operationalize care on the basis of socially vulnerable geographic markers. And this applies to COVID and beyond. While the demographic data collection has improved since the beginning of the pandemic, the data is still inconsistent and incomplete, not only for communities of color, but for all medically underserved populations. Rural communities, undocumented immigrants, people experiencing homelessness, incarcerated populations, and disabled individuals. We still do not know the full extent to which these communities are suffering. Disparities in health can only be fully understood when other data are available. We need to know about food and housing security, environmental toxins and stressors, existence of chronic conditions, and more. The National COVID Strategy directs federal agencies to increase collection and reporting of data for high-risk groups while also ensuring data privacy. With this data, we can identify high-risk communities, track resource distribution, and evaluate our effectiveness in this response. The administration's response will rely heavily on data-driven efforts to identify the communities that have been the hardest hit and to target resources right there. And this is an important step forward, building data systems that can make health inequities visible and therefore resolvable. We know that the challenge of inequity reflects longstanding and deeply rooted systemic realities, and we're not suggesting that these problems are easily solved. But we must attend to the underlying social and structural drivers as we look ahead to building resilience in our recovery. Our country is at a hopeful moment. As we look ahead to increased vaccine supply and continue to make important steps to get this pandemic under control, it's essential that we focus our efforts on ensuring that the response is equitable for all communities. Thank you, and be well.